typing their question. Oops, sorry, let me repeat that. You may ask your questions by typing your questions into the Zoom chat box, and I will then help ask these questions to Dr. Jongsma. For those who are not confident enough in their English or in their Dutch, for example, and would like to ask their questions in Indonesian, feel free to type your questions in Indonesian and I will help translate them, and I will then pass the questions on to Dr. Jongsma. Do note that this lecture is being recorded for documentation purposes. Throughout the duration of the lecture, to prevent unwanted interruptions, we kindly ask all participants to please turn off the microphone on their device. So before I introduce our guest lecturer to the audience, let me first tell our guest lecturer who our audience is. So Dr. Jongsma, in the audience today are the entire class of first-year students at the Faculty of Psychology at Universitas Indonesia. All of them are currently enrolled in a compulsory first semester course called Perceptual, Motivation, and Emotion, which in our new curriculum, the curriculum that we implemented 2 years ago, is basically a course that integrates introductory general psychology topics and introductory biological psychology topics. Also in the audience, of course, is the team of lecturers or the team of instructors who teach the course. And the students with us today to share her insights and knowledge to you all is Dr. Marijtje Jongsma, who is an associate professor in the Behavioral Science Institute and the School of Psychology at Radboud University in Nijmegen, the Netherlands. Dr. Jongsma is not a stranger to our faculty at all, as she's previously worked with us on several occasions and is currently serving as a supervisor for the doctoral study of one of our teaching staff, right, Marijtje? Right. Yeah. So I've assisted her, for example, this is more than 15 years or almost 15 years ago. Almost 15 years ago, I think around the year 2008, I assisted Dr. Jongsma when she came to visit us as a guest lecturer for a brain and behavior workshop for undergraduate students. And the most recent collaboration was actually earlier this year in June 2022, when Dr. Jongsma was invited by our Faculty of Psychology to speak about nonlinear data analysis. Just a brief background of Dr. Jongsma's qualifications. Dr. Jongsma obtained her Ph.D. in neuropsychology from Radboud University, which she followed up with several postdoctoral positions, wherein Dr. Jongsma utilized many, I believe, psychophysiological methods in her research, correct? And as an academic and, of course, an expert researcher in the fields of neuropsychology and cognitive neuroscience, Dr. Jongsma has had ample experience in the use of psychophysiological measures for investigating motor behavior and cerebral palsy and the cognitive aspects of pain, I believe. So with her expertise and experience, Dr. Jongsma is undoubtedly well-versed in topics surrounding the sensory motor system, which is, as you probably already know, Marijtje, it's one of the topics that we taught this semester. All right. I'm sure all of you can't wait to listen to Dr. Jongsma's explanation. So without further ado, let us welcome Dr. Marijtje Jongsma to begin her lecture titled Pain Perception, Research on Conditioned Pain Modulation and Placebo or Nocebo Suggestions. Dr. Jongsma, the stage is yours.
Okay, thank you very much, and it's so good to be back, even if it is online. So I hope you can see my screen, okay? Is that okay? Thank you. Okay, thank you very much. So this is a first year course, so I probably expect many questions because I have to say that this kind of really zooming into a specific topic we normally do in our second year or third year. So please stop me if I go too much in my enthusiasm and ask anything that is not clear. So today I'm going to talk about pain. I'm glad you introduced also the general topic of sensory motor, because I love this system. It's the first system that develops very early in embryonic life. Even after 6 weeks, the sensory motor loop is already completed and able to respond. So, and are very closely interlinked. Now, if I talk about pain, then probably all of you have a concept about pain. And this makes it at the same time a very accessible topic, but also a very challenging topic. Because if I would ask, can you tell me what pain is? Probably nobody has a very clear definition of pain. And this is where it already starts. It's a very, very difficult topic. So I think if I just walk around the classroom, even virtually, and ask you what's pain, you probably all can come up immediately with some kind of answer. But if you really start to think about it, you start to realize how difficult it is. So this actually, I think I went a little bit too back. This should be animated. But one of the older and more common definitions that a lot of people still use is that pain is the unpleasant sensory and emotional experience due to strong stimulation of the end of sensory nerves or elementary warning of imminent danger. And I think also the course material that you sent to me was really zooming into this aspect of pain. Like with all our perceptual systems, that we have receptors that might pick up some kind of information from the environment and then send it to the brain. So it's really like a ascending system, transveying information, damaging information to the brain. Also an old picture of Descartes, who visualized it as followed. If there is a painful stimulus, it is transmitted to the brain, and then you prepare a response. However, this definition is not valid. This is what we know as very old-fashioned tissue damage cable model, where information is just being sent to the brain. However, if you think about it, most of our pain doesn't really have outside stimulation. Yeah? The majority of our pain experiences, headache, tummy aches, whatever, are not the result of any kind of damage. And is this pain? Yes, this is actually maybe even more pain than if we have some clear-cut peripheral damage. So actually what we know about this kind of tissue damage cable model, that's very much in line with all our other sensory organs, where you get information from the environment being sent to the brain, we know as nociception. So I really would like at the start of this lecture to make a distinction between nociception and pain. So nociception is a third-person perspective. I mean, we can look at this picture and see the source and actually derive from the scene that there is a noxious information, so damaging information, being sent to the person. It is stimulus related, and it is very much linked to sensory discrimination. So we know the location, and it is closely aligned with our sensory systems, yeah, which might be warmth before you touch the fire. Now, what is pain? Until 2020, we actually had this definition, and this is the definition from the International Association of Pain Societies. Yeah. They have a very nice webpage with all these kind of definitions, and they said it's an unpleasant sensory and emotional experience. So that part remains the same, associated with or actual or potential tissue damage, or described in terms of such damage. So they say any experience that you describe in terms of tissue damage also classifies as pain. But recently, and I was actually corrected when I delivered the course last year in 2021, I gave this definition and then somebody said, no, Dr. Jongsma, it's the wrong definition. Nowadays, it's not only described, because that would discard people that cannot use language. Yeah, and they can still experience pain. So it's not only an unpleasant sensory and emotional experience associated with, but also or resembling that associated with actual or potential tissue damage. Yeah, and if we, for example, this is a patient on an intensive care unit, they nowadays also pay a lot of attention in distinguishing if a patient experiences pain. And you can even do that by observation, so without a person describing it. And I think for you, if you had to choose which situation is the patient experiencing pain, Is it the upper or the lower panel? You can, I think you will all agree that this is a situation where you should actually reconsider pain medication. And then you see that there's a lot of different expressional features associated with the pain experience. So lower brows, cheek raised, lid tightened, nose wrinkle, etc. So also if you have to assess, and this extends further than patients that are, for example, in intensive care unit, but also in neurodegenerative diseases, people that with, for example, severe dementia, infants, also lab animals. Yeah? Now, if we go to pain, then we see that it is far more a first-person perspective. It is more perception related, so pain arises in the brain, yeah? And it is closely linked to suffering. So there is a clear distinction again between nociception that we should really make early before I start the story, between nociception and pain. And most textbooks will actually zoom into nociception, which is the perceptual tissue cable model of conveying information, sending information to the brain, mostly the third person instead of the first person perspective, stimulus instead of perception related, and closely linked to sensory discrimination instead of the emotional experience of suffering. Now, apart from nociception can lead to pain, but doesn't necessarily has to lead to pain, which can lead to suffering and the expression of pain behavior. Now, to guide you through the whole story of pain perception, I would like actually to fall back on one of the greater thinkers in humanists, Socrates. And actually we use the name Socrates as an acronym to assess pain. And that is, if somebody has pain, we would like to know the site, the on-site, the character, the radiation, the associations, the time course, factors that actually contribute to exacerbating or relieving the pain, and the pain severity. And I'm actually going to take you as a tour guide along these different aspects of pain to get you a better insight in pain and pain experiences. The first one is site, and this is still very clear. You probably are familiar with this kind of picture. This is actually a visual representation of dermatomes. And dermatomes are the different parts, especially of our skin, that project their somatosensory, but also their pain information to a certain level of our spinal cord. And from there, it's being conveyed to the brain. And these are related dermatomes. And it also allows our brain to have a very specific capacity to determine where the source of our pain is when it goes about the dermatomes. So that's quite an easy one, and onset as well. You know, you always want to know if a patient presents itself with pain, did your pain start suddenly or gradually? Yeah, and did it get worse and worse, or was it there immediately? So, and it tells us a lot about the nature of possible damage. Now, the character actually is because now it gets more interesting when you go along these assessment scales. Now, character is always a telltale because we know that there's different kinds of pains. We do have, for example, nociceptive pain, which is a very much related to tissue damage. But we also have, for example, neuropathic pain, which is pain that arises really from the nerves and is very specific in character. It's often described as being a burning sensation or stabbing pain. So by making an inventory, if the pain is shooting, flashing, jumping, pricking, boring, drilling, all these kinds of fearful, frightful, terrifying, emotionally colored. So we also know, for example, that if you have a damage to your finger, the pain can be very intense, but it might not be very emotionally colored, as we say. Whereas if you have pain from your intestines or your organs, this might be not very intensive, might be a very dull and numb pain, but very emotional colored. You might feel very sick and very much in suffering because of it. So it's very helpful to make an inventory about the character of the pain, describe the pain. So, then we go to the radiation. Now, this is where it becomes a little bit more interesting, because we have seen the dermatomes, but if we look at lower parts of the bodies, we do not only have the dermatomes, yeah, which is more the superficial layers and ability for perceiving pain, but we also have the lower levels. We have the scleradomes from the bones and the viscerotomes, and here you see the viscerotomes. And these are the areas where pain manifests itself if there's something wrong with a certain organ. Now, probably you all know that if people experience a heart attack, they often have a painful sensation in their left arm. Yeah, you also see it in television series. They grasp a left arm, and this has to do with a phenomenon that we know as referred pain. So, here's all the other organs. So, for example, liver, you often feel here. Also your shoulder. So shoulder pain might actually be a sign that somebody has a problem with the liver or gallbladder, like gallstones, yeah? And so forth. And this is what we call referred pain. And this poses a problem because we cannot rely, if somebody mentions pain at a certain part of the body, that this is also the source of the pain. We have to look deeper. And then the character description can really help us. Yeah. Even more interesting, we have phantom pain. Now, and this is a phenomenon, and I think most people have heard about it, that if you have had an amputation and you lack, for example, a foot or a hand or an arm, many people who lost a limb, they report severe and very agonizing pain in the missing limb. Now, until recently, those people were actually discarded as this is just imaginary. You cannot really have pain because this leg is not there. So how can you feel pain in it? You must be imagining it. It's probably a psychiatric illness. We now know that this is not actually imaginary pain. Those people are really in severe pain and suffering. And how can we explain that? So we have to look at the brain level. So these patients very often describe a squeezing sensation or stabbing or cramping, burning, or the missing limb being in a cramped, unnatural position. And we can explain it by looking at the homunculus. So I'm pretty sure you've covered the homunculus. So this is actually a coronal slide of the brain. And we see here the gray layer on the middle part of the cortical surface, representing the different parts of the body. Yeah. So this is the face area and this is the hand area. And we know one of the nature of our neurons is that if they don't receive information, they will actually dry up. Neurons that don't get input will disappear due to apoptosis, programmed cell death. So a neuron needs information in order to thrive and also receive neural cell growth. Yeah. So if this area, if the hand is missing, and this area does not get any information, it will start to reach out to get information from surrounding tissue. And this is why very often, if you have patients which had an amputation of the hand or arm, if you stimulate the nearest area, the face, it will actually appear as phantom sensations, as if you would touch their hand. And you can even map it out. Now, to take it a bit further, because they don't really have the feedback loop of control, this might start to generate sensations of being cramped up without being able to add to it. So what we see in patients with phantom pain, that there is a lot of activations in the brain areas associated with the missing part of the brain, missing part of the body, linked to the pain system as well. Now there can also be associations of pain, and now we get into the weird phenomenon that we can have pain without tissue damage, or we can have severe tissue damage without pain. And this is a case, for example, in stress analgesia. At the brain level, our pain and our anxiety systems are very highly linked, and our survival mechanisms. So on the one hand, we really need pain in order to keep us safe and to protect ourselves against danger with our motivational mechanisms. But on the other hand, if we need to survive, we can sustain a lot of pain and actually ignore the pain. And this is known as stress analgesia. And this is a very famous recent case of Aaron Ralston. This was actually also made into a film. And he also is a motivational speaker nowadays. But when about 10 years ago, he was 27 at the time, he went rock climbing in a very deserted area in the United States. And he got into a rock climbing accident and he got his hand trapped under a bit of rock. And he could not free himself, and it was a very deserted area. So at a certain point, he realized the only way I can get out of here alive if I cut off my arm myself and then try to find for help. And this is what he did. Just with a small knife that he had in his backpack, he started to hack away and remove his arm. And this is an example of stress analgesia, because when he asked, so how could you do that? Wasn't this extremely painful? He said, I was just too focused on performing the task. Only when he had to cut through the large nerve, he said that there was like a burning sensation, but he continued to do it. And this is fascinating. So there's not a one-to-one relation between the amount of tissue damage and our experienced pain. It varies. So our experience of pain is highly modulated by top-down mechanisms and other tasks as hand. Yeah? Another very interesting pathology is SIP. Now, SIP is congenital insensitivity to pain, and it's a genetic, very rare disease. Very, very occasionally, and in some families, there are children born that do not have a sense of pain. And this is an extremely threatening condition. So they are known, and they do have normal sense of touch. They can feel temperature, they can feel pressure, they can feel vibrations, but they cannot feel pain. Now, what happens, especially during adolescence, they are very often highly risk-taking and showing off to friends because they cannot feel pain. They very often end up with severe injuries, also hospitalizations, and many of them end up being physically disabled in wheelchairs, etc., because they do not act upon pain and they do not feel pain. So this is also, some people think, can we do without pain? No, it's one of your more important survival mechanisms, and very important in your motivational systems in general. Now, the other situation also arises, which is maybe even more interesting. We can experience pain without any painful stimuli. Actually, this is the majority of our pain. Yeah? Like I said before, I mean, with headaches, there's not really a clear tissue damage cause. With chronic pain, again, there is no clear cause, and certain other pains. But we can even do this in the lab. And it's really nice that you can actually inflict pain on people without inflicting pain on people, without using noxious stimuli, damaging stimuli. And they did that in a scanner. They had people look in the scanner to body parts that were either just touched, in this case with a soft object, or being pricked, like with a needle. And what you see also, if you show people which show expressions of pain, is that you see activation in the brain in areas that normally also get activated when we experience pain ourselves. So pain empathy, as we know it, is very similar to pain experience that we have ourselves. It has overlapping brain activity. The interesting thing is if you show this kind of pictures that will normally lead to the activation of our pain centers, this does not really happen in medical doctors. They actually activate different parts of the brain that have more to do with control. So they sort of activate different centers to act upon pain in others, then activate their own pain centers in the brain. And this is interesting because I've been collaborating with the medical department. And for years we wanted to see, do people become a doctor because they don't really have pain empathy? Or do they develop this during their training? So how would doctors respond if you would study them throughout their training in medical school until the point where they become a medical doctor? So is this learned behavior, or is this a predisposition of choosing this profession? We don't know yet. Now, to take it even a bit further, that this is real pain, that if you do this kind of pain empathy research and activate the brain areas by just showing pictures of painful situations, it also responds to general analgesic medication, so painkiller medication. People that were given paracetamol in this kind of experiments actually have a reduced pain empathy. Yeah. So they have less activation at the central level, and we know paracetamol or acetaminophen has a very central effect. It acts centrally on the brain. So even our pain empathy responds to pain medication. And I think pain research using pharmacology is a very common way to see if we're really looking at the pain matrix in the brain. So I go back to the Socrates pain assessment. And the next step is time. So pain actually has this tendency to develop over time. There might either be habituation, that you know also from other modalities, that your response to a certain stimulus become actually less and less over time. So you get used to it, so to say, you get some numbing. But far more often with pain, we see sensitization, the opposite. Yeah, that people become more and more sensitive towards a certain stimulus or start to respond more extreme to it. Related concepts are hyperalgesia, excuse me, which refers to an increased pain sensation from a stimulus that normally does not increase pain. Certain patients with severe neuropathic pain syndrome even have difficulties with clothes. Yeah, they might already, like tight clothes, provoke a painful sensation, whereas normally that wouldn't happen. And then we also have allodynia. Allodynia refers to the phenomenon that a stimulus that normally does not evoke a pain response starts to evoke a pain response. So even a very light touch, yeah, or low pain might be amplified in hyperalgesia. And I'm also looking at the questions, if there's questions so far. Stress analgesia, sorry, I'm only seeing it now.
Sorry, there are two questions. Would you like me to ask you the questions? One is from our... Yeah, maybe we can take a quick break. So the first question is by an international class student. Sorry, Heka. He's asking if there are certain sites on the body, because you were talking about the homunculus earlier, right? And and also the parts of the body, the different parts, the dermatomes. So are there certain sites on the body that are more prone to higher sense of pain than others, meaning there's less tolerance for pain? And then there's another question. If you'd like to answer this question first, I'll wait.
Yeah. Yes, there are. Excellent question. Because if I go back to the homunculus, then you see that certain parts are far larger represented on the brain than other parts. Yeah, and we know that our face is extremely sensitive, our fingertips as well. If we look, for example, at the arm or the leg, yeah, so you have as many nerve endings in your leg as in your face, and you need that more. So these areas are more sensitive to somatosensory input, but very often also to painful input. There's also a huge individual difference because it's also learned behavior. And maybe you know that, you've already covered that the somatosensory cortex is also the most prone to neuroplasticity. So if we look at people, for example, that are born blind and have to learn braille reading, what you see is even at the brain level, even after 3 weeks of training your fingertips, the brain area associated with that fingers start to expand. Professional musicians also have that. So this is also trained behavior. I hope this answers the question sufficiently. Thank you.
All right, next question. This one is related to stress analgesia. Is stress analgesia related to how adrenaline also decreases our sensitivity to pain, or is it a generally different process?
Yeah. So stress analgesia is actually coupled to several mechanisms. It's not really adrenaline per se, but it plays a role, but mostly, and I'm more, how do you say that? I know more about neuroanatomy than neuropharmacology, so I always like to explain it from neuroanatomical theoretical points. The amygdala plays a central role. Now, you might have discussed that the amygdala is our core brain center for survival behavior, flight, fright, fight. Yeah. Now, the thing is that the amygdala is core in our motivational systems, and of course, pain is important to activate the amygdala for fight, flight, fright. But it also works the other way around. If you really have this high arousal that you need to flight, it will suppress your pain. And I think even people know this. So if you have high arousal urgency, for example, you're in the middle of a football game and you're about to win, you might actually get a sports injury without noticing. A lot of people have had this experience. They can badly sprain their ankle, continue until they really win the game, and then after the game notice that they have a very thick ankle and had a sport injury. So many people, so you give a preference to getting yourself in safety first, and then you start to attend to the pain. Similar with this person, so he will not be less sensitive for pain in the future, but if the moment demands, you can act upon it. Everybody can act upon it. The thing with stress analgesia and also with anxiety is it also has to do with the interpretation. And I noticed this in soldiers that got injured during the war. If they are in hospital, they ask in general for less pain medication than other people. And the thing is that they actually feel relatively safe compared to the situation they were in, leading to lower pain experience. Not that they are tougher, they endure more pain, but they actually experience less pain because their anxiety is decreased instead of increased. Yeah, and it's competing systems. They once try to stimulate the brain to decrease pain in our endogenous opioid system, but I come to that. And what you see is that there was a drop in pain experience, but a sudden increase in anxiety. So these are almost like communicating systems. Yeah. Can I continue? Is there something else?
There are actually, it's up to you. I have 5 more questions, actually. They're very enthusiastic. Would you like to answer them all now?
Yeah.
Okay.
So, because it's related to these topics, and otherwise I continue.
Right. Do emotions affect the way we feel pain? I think this is sort of similar to what you just explained in regards to anxiety, right? Is our body more prone to pain when we are unable to maintain a moderate level of stress? This is exactly what you said. Would you like to elaborate more, or do you think that sort of like
No, I think I'll leave it for now, and then we get to some more interesting topics.
Right, because that you've already explained that. I think the what I find most interesting was that the soldiers experience less anxiety and therefore less pain or more pain tolerance. All right, next question. Is the pain sensation felt during a heartbreak or when someone's offended or insulted? There's in Indonesian, this sensation or this event is actually called sakit hati, which literally translates into heartbroken. Is it also considered pain, or would it be more in line with the definition of phantom pain?
Well, phantom pain is also real pain.
Right.
Yeah, and this kind of pain. So yes, it also responds to paracetamol.
It does. Right.
I don't really. So we all know this kind of emotional pain, and I rather call that suffering. But the brain areas underlying suffering and pain are completely interconnected. So they have a lot of similar characteristics, but there's also differences. Yeah. But this kind of suffering, yes. And what we also see, but when I get to chronic pain, I will also demonstrate that we come to the opposite part. But apparently, even for heartbreak, paracetamol does have an effect. Just don't take too much. So it definitely has similar characteristics. But if you look at it, and now I miss actually a whiteboard, but if you look at pain, it's actually part of our whole ability for suffering.
Mm.
Yeah, and there is overlap with other characteristics of suffering. So, for example, trauma has specific characteristics similar to pain, but it's another. So there's overlap, but they also have their unique aspects. Emotional suffering and then and pain. Okay. But in the end, pain is really just an emotion and has very little to do with the cause of the pain. Often there is no cause of the pain. And I think this is the most important take-home message to understand pain. Yeah. And I see some questions about the congenital.
Before that, there's actually a few other questions. Yeah. Almira from Class D was wondering if she was wondering about the case of Aaron Ralston, who you mentioned earlier. How do past pain experiences influence how we currently experience pain? Will Aaron Ralston be more immune to pains in the future after going through a very painful experience? What has research shown us so far?
That will be the next part of my lecture.
Okay.
Yes.
All right. So we'll hold off.
All our experiences will actually influence our future pain experiences. But in the case of Aaron Ralston, it's actually more likely that he becomes more sensitive than less sensitive to pain.
So instead of habituated, they're sensitized. Okay.
Mostly based on our pain experiences, that will make us more sensitive to pain. And this is how the pain system is organized.
That's interesting. All right. Yeah. There's another question. Can someone with analgesia or congenital insensitivity to pain, CIP, experience distress and or other kinds of emotional pain that could result in disorders like depression, for example?
Oh, that is a really good question. And I would like to actually respond to that via email because I read an article about it. These are rare people and they did the experiment with the pain empathy. So I know they have studied it. I'm just not completely sure about the outcome. I think they were almost as good in pain empathy, but I'm not entirely sure, so I have to look it up. So they have investigated it.
So it's the sensation that they can't perceive, but the pain empathy, so the activity of the brain areas responsible for the emotional aspect of pain is still there.
This is what I think, but I'm not 100% sure. But it's really, it also has to do with the calcium channels of the. It's really at a neuronal level that does not respond to noxious input, which is highly threatening. Yeah.
So it's the neurofunctional. Yeah. Okay. All right. If you can respond by email, we'll forward it to the person who asked this question. Utari,
if you make a drop down of the chat. Also questions that I won't have time for, I will respond to it via in writing.
I've copied and pasted every question. The last question of this this batch. If a child exhibits symptoms of congenital analgesia, congenital insensitivity to pain, is it purely from a genetic basis? Is it based on a genetic factor, or does psychological factors or environmental factors influence this condition as well? especially when both of the child's parents can feel pain? Could it be a genetic mutation, for example, or?
Good question. As far as I know, it's basically almost always a genetic deficit. Now, and this is research, so even if the parents can feel pain, we still see that it can occur in a child. I've never heard about a psychological cause,
Okay.
but it might also be very early in development, so maybe congenital.
Okay.
This is why they call it congenital. So even if they cannot find a genetic cause, it is early in development, and yeah, so it's very much ingrained in the physical.
Okay, the physiology.
Central nervous system. Yeah.
Okay. All right. So I hope that answers your question, Gading, from the international class. And that's it for this batch. If you'd like to go ahead, Dr. Jongsma, you can proceed with the rest of the explanation. Thank you.
I'm going to follow up on that question. So what happens if we have a pain experience, and how does that influence our pain experiences in the future? Now, there's one very interesting, but also very scary research I find, because if you start to think about it, what the implications are, they're actually really widespread. So what we see here, everybody likes to watch baby pictures, right? We see here an infant, and I think all around the world, after an infant is born, what they like to do about 2 or 3 days after birth, they do a little blood test. It's called the heel prick. And what they do is they test the child for a genetic disorder, phenylketonuria, so PKU, and we know that it can lead to severe mental disability, but it only comes to expression if you eat certain foods, and it can be prevented if you keep the child on a diet, because it's only a genetic disorder, not being able to process these foods high in certain carbohydrates. Yeah. So it's an important test, but what they do, the mother holds the infant, and they gave only one tiny pinprick. Now, so far so good, and you can observe how the infant is responding. They don't like it, they wriggle, they often start to cry, and they have these expressions of pain. Now, what you can do is 3 days later actually start to do some kind of testing. And they did the testing with the von Frey filaments, and this kind of test is that you have a very thin stick and you put it on the skin, and the stick will just, be flexible and there will be no response. And you take increasing thickness of sticks. And you see the first stick where you start actually, because the pressure increases, where you see a response. So it's a pressure pain test. Yeah, how much pressure is needed to elicit a response? And what they saw is that in these infants, if you stimulate the foot that has been pricked before, not even the spot, they will have a faster response to pressure pain than if you look at the control foot. So this is nice, right? This infant is its own control person. So they did hundreds of infants, and every time you see this foot has become more sensitive for pain than the other foot after 3 days. So you say, okay, maybe this is just a short-lasting effect. What happens if you look after 3 months? And what they see, or 1 month, is this is very long-lasting effect. And I think even in a follow-up study during adolescence, they still can find differences in pain development systems for a single painful event. Yeah. So we see that sensitization occurs very quickly, even after one painful event, and is lasting for a very, very, very long time. So it's embedded within our pain perceptive systems. How does this work? And you probably already have learned a bit about neuroplasticity. We've mentioned it before in relation to the somatosensory cortex and the motor cortex, but there's actually a 3-stage model. So sensitization is being activated by some kind of abnormal input. Yeah. Also, it's to protect us for too much input. And you can get sensitization Sensitization means that the central nervous system becomes more sensitive to a certain kind of input, for example, by growing more dendrites, by creating more synapses, by making more connections, or by unmasking. Yeah? So you get sprouting and unmasking. And you can also get more general reorganization. Yeah? More parts of the brain can be involved in the processing of the information. And it can even lead to spontaneous central pain, similar to epilepsy. So at a certain point of sensitization, pain might not even occur based on lower stimulation from the environment, but can even be spontaneously generated within the central nervous system. So we can distinguish between structural plasticity, where we see that there can be an increase in dendritic spine density, dendritic spine morphology, and protein levels. Functional plasticity, where we see long-term potentiation, yeah, where just neurons start to fire more easily on input, and whole network plasticity. And this is also related to our learning and memory systems, cognition and resilience. And this is the real building block, I think, that's important for psychologists, because it works two ways. So yes, we can develop chronic pain at a point that pain might arise spontaneously and does not really react anymore to pain medication or medical treatment. But this is where we need psychological interventions to push the neuroplasticity another way. And here we come to time. Yeah. So this was again how we can make a distinction also between acute pain. Acute pain is pain that is very well defined in pain, but at a certain moment, due to these neuroplastic changes, pain might become chronic over time. And this is a severe health care problem. About 10% of the people at a certain point in their life might be afflicted by chronic pain. And they have calculated that it costs society billions of euros or dollars, and even a higher amount of it. So it's a high cost on society, but also quality of life. If you look at it from the brain level, and it's also very difficult to treat chronic pain. It does not really respond to pain medication the same way as acute pain. If we look at acute pain, we see that, as in all perceptual systems, information goes via the thalamus, and from the thalamus is being projected to the primary somatosensory for the localization, also to the anterior cingulate cortex for control, the motor cortex, the insula, which is related to pain perception, and the frontal cortex, which is also an important role in emotion control, pain control, interpretation, etc. Now, the interesting thing is that if we look at chronic pain, we see actually a different pattern of brain activation. We see that there is less activation in the frontal cortex, less activation in the somatosensory cortex, but an increased activation in the subcortical areas involved in the emotional aspects of pain. So the amygdala is increased in activity, and the insula and some other areas, but there is a diminished capacity from the frontal cortex and anterior cingulate cortex to actually modulate or suppress this pain. Yeah. This is also the point where we see that patients respond better to general medication that influences the subcortical brain areas involved in our emotion regulation and excessive firing. So, for example, anti-epileptic medication. These patients respond much better to anti-epileptic, antipsychotic medication, etc. So the thalamic activity is decreased. There is no input from the environment that activates the pain circuitry, but other areas. The primary cortices are less activated, but the amygdala and limbic circuitry are incredibly increased in their activity, given especially these emotional aspects of pain and suffering. Now, if you look at surgical procedures, we know that about 10% of the patients will develop chronic pain after procedure. Again, this is also the question related to the question of Aaron Ralton. Yeah, would he be less sensitive? No, probably more. If you had like a very intense painful experience, you are more at risk of being tuned to pain and generate pain even a long time afterwards, giving this problem of chronic pain. This is actually one of the more inspiring studies that we read and did research on, because it also relates to neuropsychology and our cognitive functioning. I don't know if you have the expression in Bahasa Indonesia about stupefied with pain, like stricken by pain, but what we see in patients with chronic pain, they are absorbed by the pain experience, and they also start to show decreased cognitive performance.
We say half dead. So if it's chronic and it's intolerable, we say setengah mati. Setengah mati means like half dying from pain. That's where our expression of it.
Yeah. Okay, and we can say like stupefied, like really becoming dull or stupefied or crazy, losing your mind. Apkarian is a very famous pain researcher. What he did is he had patients with chronic lower back pain. Now, this is a very common pain syndrome. People with back pain, you see them everywhere, and it may last for a long time and may be very invalidating. And what he did, he put them in the scanner and also control group. And what he saw is that the patients with pain showed a decrease in gray matter density, so brain tissue, especially in the frontal areas and thalamic areas. It's not even that people with pain showed a decrease in gray matter. It also increased with the number of years they were in pain. So it's almost, chronic pain is almost like a neurodegenerative disease. Yeah, this is also why it's so important to address pain. 1 year of pain almost equals 10 years of aging. Yeah? Pain is incredibly bad for your brain and your brain tissue. Now, this was a scanning research, but here comes the neuropsychologist, and that's our department. We said, if we do a similar study, because if they really have a decrease in this gray matter, especially in the prefrontal cortex, we expect patients that had chronic pain to also perform less on neuropsychological tests that rely on the intactness of the prefrontal cortex. And what kind of cognitive faculties are these? These are especially abilities that have to do with attention, with inhibitory control, with planning, and with switching, and inhibition. So we did that. And I take a little bit back of the previous part. Some patients with pancreatitis, which is an extremely painful disorder. And what happens is that the pancreas scars up due to a certain pathology. This can be an infection, but it can also be the result of alcoholism. For example, about 50% of the patients has a background in alcoholism. But what happens is that they get an extreme severe pain syndrome. So I was talking about these patients with this very severe chronic pain syndrome, the pancreatitis. And because previous research has shown that chronic pain might lead to a decrease in gray matter of the frontal cortex, we wanted to see if these patients also had decreased cognitive capacities that rely on the intactness of the frontal cortex. What we studied was actually a full neuropsychological test battery, because one of the criticisms in these patients was that they also use a lot of pain and opioid medication, and we know this can also decrease cognitive function, especially when in relation to memory. Many of them have a background of alcoholism. About 50% the cause of the pancreatitis is alcoholism, and we know that alcoholism might also affect our cognitive functioning, especially when it comes to regulation as well. And then another alternative confounding explanation might be that these patients also suffer from depression due to their pain or sleep disorders. But what we actually found, and we hypothesized, if it's really the pain and really the frontal cortex or prefrontal cortex, we expect a decrease in psychomotor speed, in executive functions, and in working memory. And this is actually, especially when it came to the psychomotor speed and executive function, what we did found. It was even correlated with the pain duration in years. So the longer these patients had suffered from chronic pain, the more decreased their cognitive capacities that relied on the frontal cortex were. So this is another plea how important it is to actually make sure that there's a very good intervention for pain. Even the experience of pain might decrease our cognitive abilities, which is very worrying. I'm going to skip this because I think of the wife, it is a little clip, but I'll provide it after the lecture, explaining about chronic pain from a patient view, but also how to deal with chronic pain and how it's really embedded within the whole cognitive system. Now, remember I started with the guided tour with Socrates, going to all these different aspects to assess pain. Yeah, so we had sight, we had time, etc. One of the later parts is the exacerbating or relieving pain. And one of the ways to study it, which is really interesting. So this is the question, what makes your pain worse? Or what can really diminish your pain? And you might all have heard about the placebo effect. Yeah. So the placebo effect is actually a phenomenon that if people think they get something against their pain, they might also feel less pain. And for a long time, this has been thought to be just imaginary. Yeah. So people can be easily fooled. So maybe the pain wasn't so bad in the first time. But we start to learn more and more about the physical properties of the placebo effect. And we see that there are activations in the brain that you can activate with a placebo suggestion or a placebo attribution. Now, the opposite is also true. We can also elicit a nocebo effect. And a nocebo effect actually is the opposite of the placebo effect. It is the phenomenon that if people think pain will get worse, it actually does get worse. Maybe even more important. Now, if we zoom in on the brain and the brain systems and the neurotransmitter systems involved in the placebo and nocebo effect, is what we see that with placebo suggestions, there is an increased activity in the top-down regulated endogenous opioid system. So the same system that is sensitive for very strong painkillers, analgesia, like opioid medication, morphine, yeah, and so forth. So post-operative morphine. If we look, however, at the nocebo effect, it works via a different neurotransmitter system, the CCK system, yeah, and we see an increase in activity in the CCK activity, and this is also sensitive for anxiety. So very often with increased anxiety, we also see an increase in pain sensitivity. So although the nociceptive inputs that arise in the brain, this experience is modulated by either activating a pain depression system, the opioid system, or this pain might be enhanced, amplified by the CCK system. And this is a model that we can really study in a lab setting, and which I really like to do when we do experiments on pain. What we can do is a very simple conditioning experiment. So you're probably all familiar with operant conditioning or with association, or Pavlovian conditioning, is if you show people a stimulus that is a warning signal for an electric shock, yeah, then they very learn to make the association. So you can learn people, if you see a blue circle, you will get a low intensity electric shock. But if you see a green square, you actually get a painful high shock. High is a bit thinking it. And the funny thing is, a lot of people think, why would you participate in an experiment where you get painful shocks? And I'm always amazed, but we get a lot of participants because people are very curious about pain and they know it's safe. They can set the level themselves and they're just very curious about this very short pinprick-like painful shocks. And we actually normally have a lot of participants. People are just also fascinated by pain. Now, if you do that, people very quickly learn, so this is actually little pain and this is more pain, but now you can fool around. We are psychologists. What if in 10% of the cases, I give them the wrong cue? Yeah. So I show them the signal that they will get a low shock, but instead I give a high painful shock, or the other way around. Now, this by definition will introduce the placebo suggestion. They expect a low shock, but they get a high shock, and this will induce a nocebo effect. They expect a high shock, but they get a low shock. Now, if we look at the pain ratings, what we see is if you give a placebo suggestion, they feel the shock as less intensive. And if you give this nocebo expectation, they feel the shock as more intensive. The funny thing is, even students that program the task and know how the task works still report that there are different intensities, and they say, no, this really was higher. I made a mistake in my programming. And it isn't like that. So even if you know it, and they're now also doing studies with open label placebo, it still has this effect. It's a very robust effect. We also know that there's the brain and neurotransmitter systems involved because we can also prevent the placebo effects from occurring. So we see an activation in the central pain inhibitory systems that have the top-down inhibition of pain, but we can also reverse the effect of the placebo effect by naloxone. And naloxone is a very important opioid antagonist, so morphine antagonist. So if you give naloxone, your opioid system does not respond anymore, and we do not see the placebo effect anymore. So this is a very clear physiological test that the placebo effect is organized by the endogenous opioid system. So we can pharmacologically diminish it, yeah? And we can measure it. There's a very important role of the cingulate cortex, or the anterior cingulate cortex, and also of the prefrontal cortex and the anterior cingulate. So these are areas that are involved not only in cognitive control, but also in pain control and emotion control. Yeah. And this is worrying because these are the areas, if you might remember from the previous study, that are especially affected by chronic pain. So the problem is the longer you have pain, the less capable you are to diminish centrally with your brain areas that pain experience. Now, we also know that very low in the brainstem, we have the rostroventral medulla on cells that also play an important part in this system. And they are inhibited by the opioid system, but they are activated by the CCK nocebo system, cholecystokine. Yeah? And they might make you more prone for pain experience. Now, because these are two systems, we actually wanted to distinguish a study for the endogenous opioid system, the placebo effect, and the CCK system. Because if you activate both these systems, they might actually also influence the net effect and diminish the net effect. So what we did was we presented different blocks to the participants. So they had a placebo block where they only got like high shocks and low shocks. Low shocks were always correctly cued, so they were always warned by the blue circle stating you get a low shock. And the high shocks were mostly signaled by the green square, you get a high shock, but in 10% of the cases, they expected a low shock. So this is the real nice placebo effect. Similar with the nocebo block, all the high shocks were correctly cued, only the low shocks were 90% correctly cued and 10% incorrectly cued. However, if we now compare the placebo and the nocebo block, and of course these were counterbalanced, we see that in general, in the nocebo blocks, all stimuli were experienced as more painful, and in the placebo, all stimuli were experienced as slightly lower painful. So there's also a general sensitivity that decreases in the placebo block and increases in the nocebo block. So you bring the brain in a different state. Yeah. Now, we can even take it further because a lot of people think it depends on the person. And we know that this system is very individual. It's also based on your previous pain experiences. And it's also based on other experiences and your capacity of your frontal cortex and cingulate cortex and insula to modulate pain. Yeah? So what we did was not only do this experiment, but we also looked at these different psychological, emotional, and cognitive capacities to regulate our pain. So we looked at, for example, how people deal with their perception. Some people have what we call somatosensory amplification. Yeah, they have this tendency of being very receptive of all their bodily sensations. They have a real focus on it. Or their cognition, some people might actually catastrophize their experiences, amplify their experiences, give them more negative meaning. Some might be more worrying about their health. Yeah, some might actually exaggerate physical symptoms and think with every cough they have that if they are hypochondriac tendencies that they might have a deadly disease. We all know the people. Without being judgmental, it also is based on your upbringing, the environment, experiences, etc. So before we did the experiment, we did a lot of questionnaires. We looked at the SAS, the Somatosensory Amplification Scale, that consists of questions like, when somebody else's coughs, it makes me cough too. Or when I bruise myself, it stays noticeable for a long time. I'm a very sensitive person. Yeah. We looked at the pain vigilance scale. Yeah. So statements like, I'm very sensitive to pain, or I'm aware of sudden changes, or if I take pain medication, it works very quickly. Yeah. So people that are very vigilant to pain. And we also looked at the hypochondriac tendencies. So if people worry about serious illness and are easily bothered. And finally, we looked at catastrophizing. If people are worried, if they have pain, if it will stay there, or if it will get worse. Yeah, and that's awful. So this kind of terminology. Now, interesting if we look at this effect of placebo and nocebo, modulation of pain, and we look at the net endogenous opioid effect, so the capacity to show the placebo response, that there is very little correlation between this somatosensory amplification and this placebo effect. However, if we look at the nocebo effect, then we see that there is actually a statistically significant correlation with anxiety and catastrophizing. So it's probably not placebo effect. That's very interesting. So your capacity to suppress pain, because that is quite robust and physiological. But your capacity to amplify pain, to experience more pain, is probably very sensitive to these pain attitudes. And this provides a very important insight for treatment. So it's far more important to decrease nocebo suggestions and to make sure that people get more confident attitudes toward the pain and pain modulation than to try to capitalize on the placebo effect. And for us, this was really a very important insight, that nocebo is far more salient in pain treatment than placebo. So here are some of the correlations, and you see especially with the somatosensory amplification and the Whitley index, the nocebo, so these are the p-values and the correlations. So there's a very high correlation with the nocebo effect, but not the placebo effect and these tendencies. So people with pain anxiety aggravate their pain also at the physiological level. They noticeably show a larger pain response. Now we get to the final letter of the Soccer test, the severity. But first I would like to ask if there's incoming questions, Amanda.
Yes, sorry. There is a pretty long question, actually. Sorry, I was trying to unmute. For some reason, my mouse just kept running away. It's a pretty long question, and it's not per se about pain itself, but more of the relationship between pain and suicidal thoughts, I think. I don't know if you'd like it to address it right now, or do you want to wait until the end of your lecture? Or there's another incoming question, actually. So the first one, I'll just read it out loud and see if you'd like to answer it now. So
I was reading along. There was one about suicide, right?
Yes, it's a sensitive topic.
Yes, I know.
And so people sometimes contemplate suicide because they are experiencing either intense emotional or chronic pain, and thinking that the suicide might actually end the pain. Yet emotional pain, so this suggests that emotional pain can potentially lead to thoughts of suicide. So her question is, why does chronic pain affect someone and lead them to consider suicide? What factors contribute to the development of suicidal thoughts, and can genetic factors contribute to this?
There are certain pain syndromes, very severe neuropathic pain syndromes, that we know have a very high incidence of suicide, which is horrible, especially, for example, a neuropathic pain syndrome involving the trigeminal nerve. So this is the facial nerve that can also be activated by the dentist. We all know it. Imagine that you have a chronic, constant pain from there. And it does not really respond to any kind of medication. It's so agonizing, and it never stops. And the outlook is very negative. So it's very hard. Sometimes these people are hospitalized to give them like a pain holiday and give them like high doses of anesthetics just to give them some time off from their pain with very, very strong analgesic and anesthetic medication. And they try everything. They try to cut a nerve, but the nerve pain is still there, because you know from phantom pain that even if you have chronic pain, by taking away the nerve peripherally will not decrease the pain, etc. And I'm really for this kind of severe pain syndrome, psychotherapy and especially acceptance commitment therapy is one of the ways to go, and also antipsychotic, so more central acting medication. I'd be noticed from certain severe pain syndromes, however, when we really come to suffering, so emotional pain and suicidal thoughts, this is normally more embedded within the serotonergic system, and there can be very many different causes. So I would like to leave that outside the aspect of the pain, the real depression and suffering, where it is associated with, because it works via different neuroanatomical structures and models in neurotransmitter systems, often involving serotonin, although it does have links with the pain system as well. I think the other one was about natural childbirth.
Right. And I find this one interesting because I did experience natural childbirth with no pain reduction, so it was a completely natural childbirth. So she's saying that it's actually, based on research, the actual pain or level of natural childbirth is not as high as how people perceive it. You might think otherwise once you're in that situation, but considering this information, can we see childbirth pain is considered a nocebo effect, or is it better to explain this phenomenon
Okay.
in terms of pain
And
tolerance?
I love this question. Do you know why?
Why is that?
Because this is what is happening all the time, and it's actually giving the wrong definition of pain. Because the real definition of pain is what a person says he
right,
or she
not
is
subjective.
experiencing.
Okay.
No, because this is the only real benchmark that we have of pain is. So if I
Right.
say it's really pain, it cannot be led because there's no objective measure
Right.
of pain.
It's not nociception, it's pain. It's pain.
Pain is what we experience.
Right. So different levels.
So you always have to go with what a person tells you. The
Right.
person is always right about his or her pain.
And I think
This is
yeah, I think for me personally, I think I'd like to jump in here if I'm allowed to. The thing is, when it was happening, I thought it was extremely painful. But once I got over it, I said it's not as bad. It's not as bad as I thought. But while I was, so I've experienced not experience. I didn't have any pain medication at that time. And I've experienced that while I was going through it. I said it was the most unbearable thing ever. But now that I'm over it, I'm like, it was okay. It was painful, but it was okay. So I don't know. It's not even a reliable indicator of pain for myself. I'm the same person experiencing it, and at different times of my life, I might say different things.
Yeah, this is actually a different phenomenon that's really important. We don't have pain memory. We don't. We can only use the description. So and we don't really have pain imagery. And this is also a protective mechanism. So if we have a lot of pain, as soon as the pain away, we cannot really recall the pain intensity that we had, exactly like you described. And
So
pain is somehow not really embedded within our memory, and we cannot grasp the severity of the pain we are experiencing. Also, when you are in pain, you cannot imagine what it is to be without pain.
Right.
And this is our memory system failing when it comes to pain and pain experiences.
Which I'm assuming it has an adaptive function. Like I don't think anyone would want to relive the pain that they experienced in the past. Like they try to forget how intense it was.
We have this saying in the Netherlands: if men had to give birth to children, we would only have one-child families.
That's what I said to my husband the other day, because he seemed to, whenever he's sick, he seemed to look like he's dying, and I experienced childbirth with no pain medication at all. That's true. That's true, though.
Yeah. So we have this saying, but it's highly personal. We have very little memory about it. I don't think it's the nocebo effect, but what does happen is, but I can only relate to my own experience and what people tell me. It's a very intense experience, not only pain, but an overwhelming sensation that is actually life-threatening. I mean, women used to die in about 10% of the cases in the process of childbirth. It is your internal organs, which is highly emotionally colored. And there is this overwhelming power of your muscles, like the uterine muscles are extreme. And this is like one of the most powerful muscle prestations you will ever go to deliver, pushing out a child. So I think it's adding up this overwhelming knowledge that it is life-threatening. It's overwhelming muscle power and also extreme somatosensory and pain sensation. But at the same time, your endogenous opioid system is also working overtime. If you reach that levels, and this is also after childbirth, very regularly, women need stitches, yeah? If they had ruptures, they don't need anesthesia for that. They just do it because your own opioid system is...
You're right. No anesthesia at all. They just stitched it right back right then and there.
You filled yourself up with morphine big time.
Right, with endogenous opioids, yes. So we don't need morphine anymore, yes.
Yeah, it wouldn't have any additional effect.
Right.
So, but it's extremely interesting, but very hard to study because you cannot really model it in a research experimental environment.
Right.
And I think it's also one of the privileges that you have as a mother, that you have had this shared experience with a lot of other women. So, but
and
it's
still survive the pain. I think that's one thing that I can bond over with my friends. Like, do you remember when we delivered the baby? Like, that's one thing that we could relate to together.
and also bonding. Yeah. And I think also these overwhelming extreme surges in neurotransmitters also serve the bonding between mother and child straight after birth. So there are a lot of processes happening that are very interesting and very important for survival. So I come to severity, and this also is actually a nice bridge to the next topic, which is how do we determine pain severity? And there's also one with phobia for blood and needles. I like that. That's a different topic, actually, blood and needles. This is also very physiological to this topic. Yeah.
It's not necessarily pain, but it's fear. I think it's more got to do with fear and anxiety towards a stimulus in the environment there.
Yeah, and it's also very much physiological. Some people really faint when they see blood, even if they don't really experience anxiety. And it's a very automatic nervous vagus response, not very much related to pain. But severity, one of the challenges we have in the lab is actually to estimate pain severity. And I come back saying that, okay, so this is the wrong interpretation. Pain is what people say they feel. That's the standard benchmark. That's in the definition of the IAPS. That's what we go with. So and the funny thing is I started my research actually with the Department of Anesthesiology by an anesthesiologist said, I want to have an objective measure for pain. Now, this is by definition incorrect because there is no objective measure for pain because pain is an experience. It's like asking me, I want an objective measure for the amount of love we can feel for another person. Yeah. So it's ridiculous to ask for an objective measure for pain. But how can we study pain then in a lab setting? How can we administer pain in an ethical manner? Yeah, because you cannot take a hammer and smash somebody on the hand because that would be highly unethical. And how can we measure pain perception? And how can we also do neuroimaging? So see how these brain centers respond to pain. This is actually a group. We went to a festival to run a pain experiment. They really like it in general. For example, in science museums, for science communication, people are always very interested to participate in pain research because everybody knows what pain is, has pain experiences. People seem fascinated by pain. So if you look at nociception, it becomes easier. Yes, the tissue damage scale. Nociception is really our capacity to perceive painful stimuli. We have receptors, we have pain receptors. It's different from the somatosensory system, and it leads to nocifensive behavior, so protective behaviors. And we can also have nociceptive pain. So this is acute, very strict pain that is associated with a certain external stimulus. Now, there's all these different methods that I also showed a little bit. So these are the von Frey filaments. So this is the test that they did with the infants, but you can also do it with adults. So you have these very thin threads that are flexible but become thicker and measure when they start to feel the first pain. You can also use cold and hot stimuli. So this is the thermal grill, and it has to do that if you have a high contrast in hot and cold, you can induce a burning sensation without actually using burning temperatures because you don't really want to burn somebody for real and elicit damage to the skin or the tissue. Yeah. Another one which is very safe and fun and easy is ice water. I don't know if you ever tried it, but if you stick your hand in a bucket with ice cubes This is extremely painful, but very safe. And this is what we do a lot in the lab. We say, stick your hand in and give us a pain rating and leave it in there as long as possible. And the number of seconds is a very reliable estimate of your pain tolerance. Yeah, up till 3 minutes. I lost about 19 seconds, and that's me done. Then we have the ergometer, which is the pressure pain in kilograms. You see here a 1 by 1 centimeter rubber square. You can push it on certain trigger point locations, and you can even try it by squeezing here the muscle of your thumb. If you squeeze it softly, you will just feel a squeeze. It's somatosensory system. If you continue to squeeze, at a certain moment, the sensation changes. And this is where pain starts. Now, the starting point of pain, we call the pain threshold. Yeah, and this is also a very specific, measurable point for an individual. So we can determine the pain threshold and we can determine the pain tolerance. Now, this is a VAS, a visual analog scale that we use a lot for a lot of different aspects in psychology. And that is, we can deliver a stimulus, for example, a noxious stimulus. We know there's information processing going on. And then we can say, okay, if you don't feel anything, this is a 0. But once you start to feel something, this is 1. This is your sensation threshold. Yeah, so I don't feel anything. I feel contact on my skin. And then I start to squeeze. Then I feel the first pain. That's pain threshold. And then I continue. And this is really the maximum. This is my pain tolerance. Now, what we see with hyperalgesia is that especially your pain tolerance decreases. So a painful stimulus feels stronger, yeah, than it used to be. There can also be allodynia, that a pain stimulus that did not used to be painful suddenly starts to feel painful. Yeah. And we can also use different rating scales or look at facial expressions, yeah, and also in children to point to the amount of pain or suffering. And this is the most reliable pain measure. This is what people report that they feel. This is your pain level. This is the outcome, and this is the benchmark. And then we can relate it, so it's more like backwards engineering. We now look independent of the intensity of the stimulus at this level of pain, and then we see similar brain activity instead of if we use the same painful stimulus for everybody. Yeah. Now, how the brain modulates nociceptive pain is that if we have incoming pain, and this is the red descending system to the brain, so a noxious stimulus is being picked up by the pain receptors at synapses on the dorsal horn of the spinal cord. It's being ascended, so projected to the thalamus, and from there it's being projected to the primary somatosensory cortex and the insula. So that's the incoming pain information. But we also have a descending system, which is even more important, that I already discussed a little bit. And this is the system that can modulate and inhibit our pain, coming mostly from the prefrontal cortex and the anterior cingulate cortex, yeah, and limbic areas. And this system actually projects down and decreases the pain by decreasing activity in the thalamus, but also at the level of the periaqueductal gray, which is very rich in opioid neurons, and the rostral-ventral medulla. Yeah. So we have a pain ascending system projecting noxious information to the brain. And then we have this whole system in the same hemisphere, but for graphical reasons projected in the other hemisphere, that decreases or modulates our pain. It can also increase the pain. So pain is a combined product. Yeah? It's a product based on our perception, cognition, arousal. Yeah, if we are aroused, we may not feel the pain. And if we are more relaxed, for example, at night in bed, you might be more bothered by a headache than when you are busy and not distracted. And our emotions, are we scared or not? Are we worried that the pain signifies a terrible disease or not? So this all modulates the pain experience. Now, what's interesting, we can actually directly measure the system for modulating our pain, decreasing our pain. So this descending opioid system. And we can measure this by conditioned pain modulation. And it's a fun test, and it's very easy to do. We do it a lot with our thesis projects, students that want to run an experiment. And this is how it works. You give a brief, painful stimulus. This can also be an algometer. Yeah, you can even use a weighting scale, put a hand on it and see how much kilogram pressure people can have to have their pain threshold. Then you ask to stick their other hand, so another part of the body, in the ice water bucket and measure their pain tolerance. Yeah? And this is a longer lasting painful stimulus, and during this time, your endogenous opioid system becomes activated. Now, if you start to measure the pain threshold again after the exposure, what we see is in general that the second time your pain sensitivity is, you're less sensitive to pain, so you need a more intense stimulus to reach your pain threshold, because you have produced a lot of endogenous opioids, like during childbirth, but a bit less extreme and a bit easier to modulate in the lab. So we see that also in a numeric grading scale, if you give a shock in this case before the ice water, it has a certain level, but it is suppressed after exposure to the ice water bucket due to your endogenous opioids. Now, why is this an interesting test? They have discovered that it is a very predictive test in patients if they will develop chronic pain after surgery, for example. So people that are not very good in producing endogenous opioids, so their own morphine, are more at risk to develop chronic pain than people that have a very good and clear suppressive response in this test. So are you capable of making your own painkillers or not? Yeah. Now, this is known as CPM, conditioned pain stimulation and modulation. We use it a lot in the lab. And it activates the endogenous opioid system. And we know that because we can counteract it by naloxone. Remember, naloxone is an opioid antagonist. And if you give people naloxone, they will not show this CPM effect, this conditioned pain modulation. Now we know that the areas of interest are the periaqueductal gray that produces this endogenous opioid, and the rostral ventromedial medulla that has the off cells activated by the opioids. We know that there's this clinical relevance. If you do not show this pain suppression, you are at risk for developing chronic pain. And also we know that this is a dynamic system. It changes based on our experiences. If you have had a period of opioid pain medication, the system works less efficiently. Yeah? It decreases your own endogenous opioid system. And this is quite interesting because they have now trials that people that have a chronic pain syndrome, for example, fibromyalgia, I don't know if you're familiar, but these are people with constant pain in their joints and muscles. Yeah. And apparently their CPM system is not really working. They do not produce their own opioids. But if you now give them a very low dose of naloxone, blocking the opioid system, which sounds counterintuitive for a longer time, their opioid system might say, hey, we don't get any information. We are blocked by naloxone. We have to become more sensitive. We have to start to work harder. It's almost like you have an elastic band and it has reached the end of its elasticity. If you tighten it, it will start to work again. So you can repair this endogenous opioid system apparently by giving it low dose of naloxone, urging it to start to become more active again. Yeah? So it's not at the ceiling effect. There's even other more social factors, and this will be the last experiment I will explain, because I think we're also running out of time, but I'm also looking at due to my lost connection, which I apologize for. Is everybody has this experience, especially with children, that if they have pain and you cuddle them or you give them a kiss, also the pain decreases. Like having the social caring behaviors probably will increase oxytocin, which is our cuddle hormone, that might also activate our opioid system and decrease pain. Yeah? And also rubbing, but this is also the gate control, and I think you've studied this in the book, that somatosensory input also competes with pain information and suppresses our pain experience. And this was really fun because we tried this in an experimental setting. So this is some of the gate control, that if we have pleasant touch and sensation, we get input also in the system and activate our central pain modulating system. Yeah. Now we had this question, does it work if we do this in a lab, like standardized hugging, just sitting on a lab and with a 1 Hz frequency, just giving a stroke on the spine of the back? Yeah. And does it decrease pain stimuli, or does it increase our endogenous opioid system, which is two different things? So in the first case, if it would just decrease pain, then people would have lower pain thresholds the first time when you test it. But if it increases our endogenous opioid system, it would increase the CPM effect after the ice water bucket. And I hope you agree that these are two different tests. So it's not a direct pain suppressor, but indirect by increasing our capacity to produce endogenous opioids. Yeah. Now we did this, so this is the lab, this is me. We had standardized in a lab coat. During the ice water bucket, people could sit on the experimenter's lap and they had 1 Hz stroking, standardized hugging. Yeah. And they were either by somebody unfamiliar, the experimenter, so it's not a relation, or the partner. So we also had this combination. Now the pain threshold was determined by electric pain, the pain tolerance by the ice water bucket, so the number of seconds, and the CPM effect, so the efficiency of our own endogenous opioid system, by seeing the percentage of pain threshold increase. Yeah. And then we compared people that received hugging, either by an anonymous person or the partner, or without hugging. So these are the numbers. So in total, there were, we also compared singles and couples for the experiment at the festival. And what we found is that indeed hugging increased this capacity or the working of the endogenous opioid system. So it helps to actually kiss it better or console people and hold them. And it even works better if people don't have a partner, if they're single. They're probably more receptive for this effect. But the effect was equally large in singles and in couples. So it seems to work, but not directly. The pain thresholds at the pre-meeting were similar. It was only in enhancing this endogenous opioid system effect. So you're suppressing the system. Now, and I think this is the final question and take-home message, is to ask, how valid is pain research? And the problem is, I really like this paper, they actually did a research to it, is if you advertise an experiment for participants, we cannot tell participants that they have to participate in a certain experiment, because that would not be ethical. So we rely on our volunteers, and apparently volunteers for pain experiments are different than general volunteers. So they are not representative for the whole population. These are people that score higher on adventure seeking, ADHD-related behavior, dopamine 4 receptor antagonist interested people. So they are already tuned on getting painful stimuli and willing to participate in this kind of experiments, which puts questions how reliable experimental or these kind of pain experiments are. And it is a take-home message also for researchers that it's also important to study natural patient groups. So we try to do both. So our pain research is directed both at group of patients with chronic pain, but also on volunteers that think it's fun to do these tests to study their own pain system. So I suggest we have a final round of questions, Ermanda.
Yes. Well, there's one last question. And I think this could be our last question since we're running a bit short on time. So hypochondriac is linked to the nocebo effect, which makes people who worry about illnesses become ill themselves. And the advent of the internet has led to a modern form of hypochondria called cyberchondria. I guess this is where people try to look up like symptoms and try to match their symptoms with a specific diagnosis. Yes, Googling minor symptoms often produces a long list of possible illnesses like a headache, a migraine headache. Oh, do I have meningitis? Oh, do I have this? And my husband does this actually. Could this phenomenon cause an increased rate in actual illnesses? Like the anxiety associated with like the potential or the possibility, or even if it's misled information, it's like misleading information. You know how people sometimes self-diagnose based on what they find on the internet. Could this potentially lead to increased illnesses and the rates of illnesses among the population?
This asks for more research, I think. I think it's a very good and valid question. And it is in line with all the worries we have about social media and internet, right? It's also about misinformation. It's also about also with social media and having unwritten rules about how to behave on social media. So it's all related. So I think the whole popularity of internet and all these novel communication modes actually develop more rapid than our adaptation and how to deal with it. So personally, I think having a tendency for hypochondriac is not caused by the internet, but can be aggravated. But the tendency is there. If people previously had to go to a library, it can also work the opposite way. If you have, for example, access to good and reliable internet sources, it might actually be diminishing hypochondriac. And we see that now the medical, I don't know about Indonesia, but in the Netherlands, the medical system is relying nowadays a lot on apps and a lot on web pages. For example, if I want to make an appointment with my GP, I'm redirected via their web page to the internet GP and do a symptom check if I really need to see a doctor or not. So they even try to diminish this and even try to see also with physiotherapists. I had a sport injury the other day, and they showed me to this internet page where you can do all this physiotherapy tests yourself. Said, try to stand on one leg. Does it hurt more when you move left to right or not? And then they come and I said, come in, and then they start to ask, so did you try the internet page? What did it give you? So, and then it makes it more efficient. They only have to do 2 or 3 more tests and confirm it, and then come with a good advice. So it can work both ways, but I think we need to adapt, and disinformation in general, also when it comes to politics and when it comes to complot theories. This is a real worry, and I think the whole educational system should be really aware of teaching people how to use the internet sensibly.
Mhm.
It asks for attitudes, and I think especially psychologists can have and educational psychologists can have a very important contribution to this field.
Mhm. All right.
And I think I like to wrap it up. If you want me to squeeze in my final 10 minutes at another point of time in the course, I would be more than happy. Again, I would like to apologize sincerely for the terrible power cut down. We never really.
Well, maybe in the Netherlands it's not common, but we deal with it on a daily basis, so very, very acceptable on our part.
It was the first time, and I feel really bad, but I hope you enjoyed the lecture, and I will have a quiet look at the questions if you send them to me, and if needed, I will respond to it in writing.
I think you answered all of the questions. We managed to squeeze in the answers for all of the questions.
Good. I'll send you the PDF also of the slides.
Well, okay.
And a little more of your chronic pain.
We'll disseminate it to our students as well. So thank you, Dr. Jongsma, for having so kindly shared your knowledge with us. I'm quite sure by the amount of questions that we've been getting in the middle of the lecture, I'm pretty sure that a lot of our students enjoyed your lecture and were curious about pain. I'm even more curious than I expected, actually, because a lot of the questions were questions that I didn't expect coming from them. But and I think you beautifully wrapped up your presentation by saying that the main takeaway point at that end of the lecture, and of course, if our students have any questions about pain, and I think a lot of, as you said earlier, a lot of people are just simply curious about pain, so they don't mind tolerating a little bit of pain just to contribute that, as long as they can play a role in the knowledge about pain and like expanding the knowledge about pain. So I'm pretty sure a lot of our students are also as curious about pain. So if are they welcome to email you if they have any questions about okay.
Sure.
We will provide you with I'll provide them with your contact. All right, so that's all the time that we have. Unfortunately, we can't take any more questions. It's already 4:06. Marijtje, do you have anything else to add?
No. Maybe. Yeah.
All right.
We can wrap this session.
Okay, thank you so much, Dr. Jongsma.
You as well for the moderation, and Sampa Bitimalagi, I really hope to be back, especially in person. So
yes,
hopefully next time
hopefully you'll come here again and we'll meet.
Okay, for sure. And I also mentioned it, but I think this is more for people at a higher level in the study, so not the first year, but there are some possibilities to join a hybrid pain course at the Radboud University. But I'll provide information to Inge as well. I sent you some information about that one.
Yeah.
Okay.
I think it's a really nice course for international collaboration and making optimal use of the novel hybrid facilities we have.
Right. All right.
Okay.
Thank you so much for your time, Dr. Jongsma.
Thank you for all your questions.
But Inge, do we have to take a picture or no?
Okay. Maybe we can take a picture. There's like 12 pages here for the students. Please, you can
if you can
on your camera.
If you look decent enough, you may turn on the camera so we can take a picture together.
Okay.
Do you have any engagements that you have to attend to, Dr. Jongsma, or is it okay if we spend like 2-3 minutes to take a picture?
Yeah, that's okay.
Okay, thank you.
Okay. Maybe while waiting another pages, I will start with the first page, yeah?
Some of them are on campus.
Okay. So 1, 2, 3. First page. Okay.
It's so nice to see the students now.
Yeah.
Finally, after 2 hours, you can see their faces.
Okay.
And then colleagues and familiar faces like Bagdani and yeah.
Okay, second page, please. 1, 2, 3. We don't know in which page you are, so you need to
smile. Just smile throughout the process.
Throughout the process. And then
and you have to freestyle all the time.
Yeah.
Yeah,
okay.
you can freestyle
last time. Yeah.
Hey, see, Dr. Jongsma is doing the Korean thing, the Korean heart thing.
Okay. That's nice. Okay, third page, yeah. 1, 2, 3. Okay,
Make sure to
maybe
comb
this
your hair
last
before
page.
turning on the
Yeah,
camera.
yeah. Only 3 pages, Manda, who turn on the camera. Okay, we
Okay.
can finish with the 3 page maybe. It's okay. Thank you all. Thank you, Dr.
Alright.
Jongsma.
So much, Dr. Jongsma. See you soon.
Hope to see you
Thank
again.
you,
Bye.
Dr.
Yeah, hope
Jongsma.
you see you.
Bye.
Yeah,
Thank you.
bye.